We are so excited to welcome you all to another inspirational and educational episode of Concord Conversations. Concord Conversations is an initiative by Concord Medical Group to educate, empower, and encourage our community about our health so we can all live to our full potential. Today's episode is Behind the Images, what your mammogram results reveal. Hi, I'm Dr. Kathleen Weinberg, Director of the Adult Congenital Heart Disease Program here at Concord Medical Group and Northwell Health. And today we are joined by our outstanding colleagues from Lenox Hill Northwell Health. I would like to introduce you all to the amazing Chief of Breast Imaging, Dr. Lisa Barron, and the Director of Breast Cancer Program and Chief of Breast Surgery, Dr. Paul Barron. Our community have submitted fascinating questions, which we're going to ask our experts today. We are giving general guidance. If you have a particular question about your health, we want to help you. So come in and talk to our exceptional Northwell physicians about your health. Let's get started. Okay, welcome, Dr. Barron and Dr. Barron. We're so excited for you to join us today. Thank you so much.
Thank you.
Why are mammograms so important, Dr. Barron?
So I'll take that question. First of all, I'd like to thank everybody who's on this webinar and who reviews it after the webinar. It's probably one of the most important steps that you can take for your health. We know through the past 30 to 40 years that we've been doing mammograms that women who participate in routine screening, these are just patients who are asymptomatic, have a 30 to 40% lower mortality than women who are not receiving routine mammograms. And that's a huge difference. And why would that be? Mammograms are a screening test, similar to airport security, where we're looking for symptoms or findings for breast cancer. And those include calcification and densities and masses. But mammography is not perfect. We do know that women who have dense breast, which is about half of women that we screen, it makes it hinder our ability to find breast cancer. And what is dense breast and why is that important and why are we hearing about it? The density of the tissue, the glands, are white on the mammogram. Fat is black. And so the patients who have mostly fatty breasts, it's easy for us to pick up a mass. But those who have dense breasts or white breast on the mammogram, it makes it very difficult for us sometimes to see cancers because some cancers are white. And so you have white on white. And that's why women who have dense breasts now are being notified that their tissue is dense and that additional testing with ultrasound or MRI can be helpful to detect tumors. Breast cancer, we also find it with calcifications or asymmetries. And so one thing I want to talk about is how often should patients receive a mammogram? The general guidance for people who are low risk is every year starting at age 40. Dr. Paul, can you talk about how we're identifying women who might be at increased risk for breast cancer and might need additional earlier screening mammograms or might need MRIs or ultrasound or might have a genetic mutation? Can you speak further on that, please?
Sure. So we have a high-risk program here where we obviously take a thorough family history of the patients and relatives of breast cancer, ovarian cancer, and we usually use software called Tyrer-Cuzick or IBIS, which you put in factors like family history, age of first menstrual period, age of first child, and it spits out a number is what is their lifetime risk of developing breast cancer. And if that risk is 15% or less, then they're considered average risk, and then they use the mammography screening you heard about. If their risk, on the other hand, is 20% or higher, that's a lifetime risk of breast cancer, then they're considered high risk. And those patients should actually start mammography screening earlier. And in some instances, especially if they're over 20%, we usually recommend MRI. So commonly in these patients that are high risk, we actually have an alternating pattern where we'll do a mammogram and then 6 months later, they get an MRI, and 6 months later, they get a mammogram. So every 6 months, they're getting screened. The other tool, which you mentioned, was genetic testing. We do a fair amount of genetic evaluations of our patients. We have 2 genetic counselors in our program here. And so if there are kind of 2 groups, there's the high risk patients like we're talking about here. Those patients will take a thorough pedigree on them and look at their calculated risk and try to see, is there a pattern that patient would benefit from genetic testing? The other group are the patients who have newly diagnosed breast cancer. And commonly we also offer genetic testing to virtually all of those patients. And we actually have a software program for that where they watch a video, and this is out of the Northwell Cancer Institute, and they get genetic testing. So it's very valuable. And the days of genetic testing now are very different than they were 20, 30 years ago in 2000 when we started doing this. And that the cost of it, the test has come down dramatically. It used to be over $4,000. Now, in most cases, it's about $200. Most time, the insurance will cover it. If they don't, and we use this tablet with this software that I mentioned, then it's usually covered. So, but I will say, we spend a lot of time talking about genetic testing, and even our patients who have breast cancer, the chance of finding a mutation is generally only about 4%. We used to think it was higher, but it's only about 4% have a gene mutation. Obviously depends on family history and things, but it's relatively low. But if you have a gene mutation, especially a BRCA1 or 2 mutation, then their lifetime risk of breast cancer is as high as 60 to 80%. And that's very significant with these patients.
Okay, so let's talk about what a mammogram actually is. How does it detect breast cancer, and is it painful?
A mammogram is a very, 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 very low dose X-ray of the breast tissue. And when you come in for a mammogram, the technologist will get your history. They might mark areas if you have moles, or if you're coming in for symptoms, if you're having a mass, they put a little marker on there. And we typically will do 2 views of each breast, and then we review it. And so what am I looking for when I review a screening mammogram? I'm looking for, especially if patients have older mammograms, we're looking for any change, because breast cancer is not just breast cancer. It presents in many, many different ways. For some people, it may present with calcifications. For others, it's a mass. For others, it's just a little change in the density. And when you come in for a screening mammogram, typically you come in and you leave. But every now and then you'll be called back for additional views. And this is a very, very small percentage of women in the Northwell system are being called back for additional views, about 5 to 8%. And when you come in for additional views, you might have some more mammograms, you might have an ultrasound. And then sometimes if we find something that's suspicious, we might recommend a biopsy. And so for a moment, I just want to talk about, in general, what biopsies are, where they're done, what to expect. Typically, when we do biopsies, they're done in the outpatient setting. They're very, very, it's a simple procedure. It's not something that you need to really prepare for. When you come in, we get another history, we get the consent form to do the biopsy. Biopsies are generally done with either a mammogram or ultrasound. We try to do it where we see it best, so we can be accurate in terms of the biopsy. We basically wipe the skin off, put lots of Novocaine so you don't feel it, and use a special biopsy needle just to take out little samples of tissue that we then give to the pathologist to further examine it. Typically, it's about a 3-day waiting period before we get the results. The pathologists are very keen on trying to rush these as quickly as possible, but they do need time to prepare the slides and to study the slides. And so that's why it's not instantaneous. Once we get a diagnosis of cancer, the patients are referred to the breast surgeon, and then they take it from there to coordinate the care. So maybe, Dr. Paul, you can talk about what happens if a patient gets diagnosed with breast cancer and they're referred to the surgeon, and then can discuss maybe the team approach that we have at Northwell to try to individualize and expedite treatment.
Well, we look at the imaging studies, we examine the patient, we take their history. So most importantly, is the patient based on their body habit, is amenable to a lumpectomy, or do they need a mastectomy? Most of our patients are able to get lumpectomy, where we just take out the tumor with a rim of normal tissue around it. In some cases, we'll add an MRI to the imaging if they have a new cancer, because we may feel that the tissue is very dense and there may be more information gained by that. And when they do the MRI, they look at both breasts when they do that. The MRI also is done in patients who, if their tumor is considered a high-risk tumor, such as a triple-negative cancer or a HER2-positive cancer, we'll frequently consider them for neoadjuvant therapy. That's where they get chemotherapy and Herceptin first, and then do the surgery afterwards. And those patients will also get a baseline MRI at the start of therapy and at the end of therapy before they have surgery to evaluate for response. And luckily, we're able to do breast conservation. Most patients, again, lumpectomy, as I mentioned. In some patients, we'll couple it with what we call an oncoplastic procedure. And what I do in those cases, I try to move the tissue around so cosmetically it looks really good, and I try to hide the incision as often as possible. If a patient has a lot of extra breast tissue or a lot of what's called ptosis, we'll frequently have a plastic surgeon there to do a reduction with the operation or a lift, and that way they can use that tissue to help fill the defect. And the patients really like that. The other thing we're doing is whenever a patient has to get a breast cancer operation, we usually stage them. We do what's called the sentinel node biopsy, where we take out the first node the cancer goes to. So it's very rare we have to do a lymph node dissection. So it's very rare that we have problems like lymphedema, which used to be a common problem. So the buzzword these days for breast cancer treatment is de-escalation, meaning we're doing less of everything. We're doing less surgery. Again, lumpectomy, which is an outpatient procedure. For those patients who need a mastectomy because they have multifocal disease, or they don't have enough tissue to have a lumpectomy with a good result, or they have, let's say, a BRCA mutation. They'd rather have mastectomies and not have that. We'll do what's called a nipple-sparing mastectomy, where we save the skin of the breast, save the nipple, and the plastic surgeon comes in and reconstructs the breast, and the cosmetic results from that are great. The other area where we do a de-escalation is by giving chemotherapy up front sometimes. We'll convert a patient from somebody needing a mastectomy to a lumpectomy. And lastly, the new thing we're doing is we're doing less and less to lymph nodes. We're doing to lower the risk of lymphedema. So in the old days, everybody had lymph node dissection. Mostly we were doing sentinel node biopsies, but now it's rare to go back and do lymph node dissection. There was recently a big trial published called the SOUND trial, where in many cases now we're not even doing a lymph node biopsy in patients who are getting surgery for breast cancer. So we're doing less and less surgery with the same outcomes, if not better outcomes, better cosmetic results. And the patients are obviously much happier with all that.
All of the patients really appreciate their personalized care you give them, that you make sure cosmetically it looks good. It matters to women. So, and that they're getting appropriate care for what they need if they don't need a lymph node biopsy. Dr. Byron, you were going to add something, Dr. Lisa?
Yeah, I was going to add that we have a team approach at Northwell for patients who are diagnosed with cancer. Our team approach includes the surgeon, the radiologist, the radiation therapist. We have nurse navigators, the oncologist, and we meet at a working meeting every week to discuss patients and make sure that everyone is getting optimal, individualized care. Because one thing that's important if you are diagnosed with breast cancer is you might be talking to a friend or a neighbor and they said, well, I had this and this, and that doesn't matter, because each patient is an individual, and we want the journey through breast cancer treatment and getting on the other end to be individualized and to resume the patient to their standard of living.
So there's a couple questions in the chat box. They're really talking about just differentiating the different types of exams we can do between a mammogram, a 3D mammogram, CT enhanced mammogram versus an MRI versus an ultrasound. Can you talk a little bit more about each of the tests and why you would choose one test versus another?
3D mammograms are pretty much the standard of care. At Northwell, all our machines are 3D. It provides better coverage of the breast. It's part of the advancement in breast imaging. So patients don't need to worry. If you come to Northwell, all our machines are 3D. It's just a higher level of mammography. Ultrasound is done for people with dense breast and patients who come in with symptoms, maybe a mass or a nipple discharge or whatever. It gives us additional information, and it's complementary to the mammogram. The thing that the mammogram and ultrasound have in common, it's more structural. What do things look like? Is there a mass? Is there an area of distortion? The next test is, and the standard of care is the mammogram. The CT mammograms, there are some in the city. They really have not been studied to change detection or increase or decrease mortality. It's something that few places have, and it's not better than a mammogram. It's just maybe an alternative. It's not standard of care. We do not have CT mammograms for the reason that we do 3D mammography, and that's the standard of care.
Can you comment about contrast enhanced mammogram?
Yes. So then there's contrast enhanced mammogram and MRI. So MRI and contrast mammography are based in putting contrast into the body. The contrast goes throughout the body. And what happens is that tumors typically have leaky vessels and take up the contrast and make it easier for us to find. So contrast enhanced mammo and MRI is functional imaging, how the tissue is behaving. And so that can be very, very helpful to establish extent of disease, because what our goal is to treat the cancer the first time, make sure there's no other cancers in either breast, and to optimize treatment. And so in some patients, depending on the tumor characteristics, or if patients are high risk, we add an additional functional imaging to the armory of us trying to make sure that there is no other cancer present, or if there is, that we can biopsy it and be able to get the patients to get the right operation the first time without having residual disease. So about 15, 20 years ago, we did not have our MRI, or the functional imaging, did not have the contrast enhanced mammography. And some patients reoccurred, or there were additional cancers that we couldn't detect. And now the technology has really improved everything that we're doing to evaluate and assess the breast tissue.
Well, it's really exciting to hear that the imaging is getting so much better. We can detect things so much earlier, and we can really treat our patients appropriately. So, Dr. Paul Barron, you're the lead of our breast program at Northwell. Can you tell us why Northwell's breast program is so special?
Yeah, we're very fortunate to have really outstanding physicians and also other providers who work with us. We have Navigator, we have radiation therapy, who is excellent. We have medical oncology is excellent. Probably the best pathologists for breast pathology in the city, and obviously a strong radiology group with outstanding radiologists. And I'm obviously a little biased, but that's the way it is. But we work as a really good team and put a lot of value in very personalized care for these patients. So I spend a lot of time with folks, and I'm always available for questions. As you heard already, we have a weekly breast cancer conference where we present the new cases. And we have a team approach on evaluating these folks. We actually also have a system conference every month, which also these cases get presented at, or other additional cases. So the very personalized care we have is excellent. The new exciting thing that's coming down the pike is we have this beautiful new building getting built on 3rd Avenue called the Goldman Pavilion, but it's pretty much going to be housing the whole cancer program. It's going to have breast surgery, it's going to have breast imaging, it's going to have radiation therapy, medical oncology, and it's really going to be a beautiful building that fits with all the other nice buildings in New York, if not nicer, and it's got a lot of cool things about it. And I think the patients will like it. It's actually 1 block from the hospital, so in case just give you bearings where it's going to be. Other things we do which are special, we have a grant for providing all our newly diagnosed breast cancer patients are offered a virtual exercise program We have this outfit that does virtual exercise with them once a week for an hour, and it gives them homework. There's really solid data for those patients who exercise regularly. Even though they may get diagnosed with cancer, they seem to have a better survival once they're diagnosed. Also, we work with patients on same sort of things you guys do, where diet and exercise is also important. That plant-based diet has a better survival of breast cancer. Minimal alcohol is very helpful too, to lower the recurrence rate. So there are a lot of things we've got going on here. We're really a multidisciplinary approach with really outstanding clinicians, and we're very fortunate to have that here. And you know who your doctors are. It's a relatively small but outstanding group. And we recently obtained NAPBC accreditation, a national accreditation program for breast centers, which gives us a stamp of excellence on our program. So we're very proud of that.
You've accomplished a lot in a little bit of the time that Northwell's had this expanded their program, and we're really excited to see what happens. Dr. Lisa Barron, there's a question. Someone in the chat box just wanted you to elaborate a little bit more about that even low-risk women can get breast cancer.
So the biggest risk of getting breast cancer is being female and growing older. So it's a cancer of aging. It's a cancer of being female. We don't have all the information of why people develop breast cancer. Right now, we're testing about 60 to 70 genes, but probably in the next couple of years, we'll know more. And most of our patients, as Dr. Paul alluded to, do not have any genetic mutation. So that's the challenge. And we know that for average risk women who are getting mammograms consistently, they have a 30 to 40% lower incidence of mortality. And so we have that experience, and it's not only the United States, it's Sweden, it's Europe, and it's throughout the world. When we look at the studies over the past 30 to 40 years, they're consistently showing that. Probably one of the few tests that we do that really has an impact on people's lifespan, besides cardiology, of course.
By the way, I want to go back to my comments about genetics. Please understand, I wasn't undervaluing the value of genetics, because when we do find a mutation, those patients have a high risk for cancer, but also it's very important for their family. So if they're found to have a gene mutation that increases the risk for cancer, then if they have any siblings, children, parents, then they also need to be tested. It's called cascade testing. So there's a lot of value. So we still offer the testing to virtually everybody who has cancer, because we've only found a very small percentage of all the patients who are carriers of these gene mutations. And so to me, it's a crime when you find a patient with cancer and they have a BRCA1 mutation. And if they had known it earlier, they may have been able to avoid chemotherapy. They may have been found earlier and have a better prognosis. So I think it's very important that genetics is also a very key part of what we do here.
Hopefully we have time for another 2 questions. There's a comment in the chat box saying that she has their mammogram, but she has dense breasts. And unfortunately, Medicare doesn't cover dense breast ultrasounds anymore. Is it necessary to get it, the ultrasound?
Okay, so this hot topic. So in January this year, Medicare works on a balanced budget, and they were looking at other things that they're covering and things they could decrease. And a decision was made without guidance from professionals such as radiologists and surgeons and medical oncologists of the value of doing screening ultrasounds. And so really, it's sad that Medicare made that decision, that they're not covering screening mammograms. So the answer to the question is yes. Just because Medicare doesn't cover the ultrasound, the screening ultrasound, it's important for each patient to decide if they're going to pay out of pocket. Usually most centers have a map, we know what's going on. And so I think at Northwell, it's a fixed cost. So you know what you're going to have. It's a trade-off. I'm sorry that Medicare did it. This is something that you need to write your congressmen, your representatives, because there was no public hearing about it. It was just a decision that was made on budgetary reasons. We do find cancer In a lot of my talks, I specifically show dense breast, and I show how ultrasound found a small cancer, which really redirected the patient's care, because by the time they find it on clinical exam, it's larger and more challenging to treat with more treatment, either chemotherapy or surgery. So just because Medicare is not paying for it, the state of New York is working hard on creating legislation that insurance companies need to pay for ultrasounds. That hasn't come through. There's a lot of discussion about it. But again, I think for Medicare is you write your representatives and continue to write them, because this was a decision that was made by Medicare in a void.
So our last question, if you have one action step to recommend to our viewers and improve their health and start today, what would it be? Dr. Lisa Barron, do you want to start?
Yep. Get your mammograms. For the average risk person, get your mammograms starting at age 40. If you're dense, have a discussion with your doctor about doing additional testing, which is usually the ultrasound. The other thing I'm going to say, this is all under one thing. If you feel something, say something. So the mammogram's not 100%. Especially if you have dense breasts, if you have change in your clinical exam, please notify your healthcare provider.
Dr. Paul Barron, would you like to add something?
Well, it's basically the same thing. If you basically make sure you get your screening mammogram, it's also important to do a risk assessment. So if folks are doing that, great. If they're not, and they sense as a high risk, they have a lot of family members, whatever, we'll be happy to see those patients. There was a story about 8 months ago where this movie actress, Olivia Munn, had breast cancer, and it was found because they did a risk assessment. They did what's called Gale risk model in that case. And it was elevated, so they got an MRI, and they found a small cancer on her, and that led to what she went through. So it's important to evaluate every patient individually, and those patients, especially if they have family history, should be counseled about their risk. And of course, the other things that go with it, as I mentioned, in addition to the mammographic screen, which is most important, they need to be evaluated. Do they need an MRI? If that risk is elevated over 20%, they need it. And the dietary and just lifestyle changes are all you guys are recommending for primary care. Same thing with us. It improves the survival from breast cancer. So that's important. But it doesn't stop 30-year-olds who are very healthy showing up with breast cancer. They still get it, and they don't have a gene mutation. We still don't know why a lot of patients get breast cancer. So, but if they are found with it and they have a healthy lifestyle, they do have a better prognosis.
Well, I think what makes your program so special is the individual care you give women, and that you really support them throughout the entire process. And that's very special. Thank you all for joining us for another inspirational and educational episode of Concord Conversations. A very special thank you to Dr. Lisa Barron and Dr. Paul Barron for joining our conversation. We appreciate their expertise to educate, encourage, and empower our community. And as part of our Concord community, we hope you'll share in our mission. Please pass along our emails and webinar links. In addition, please like and subscribe to our YouTube channel. We know many of you have additional questions about your health, and we want to help you. So come in and talk to our extraordinary Northwell Healthcare physicians about your health. We care about your health. We care about you. Thank you so much for joining us.